So this is a case presentation of post-operative complications following a connective tissue graft. And I'm Peter Halford, and I worked with one of my colleagues, Aditya Patel. Teacher and program director was Dr. Deborah Matthews at Dalhousie. So the presenting patient, she was a 39-year-old female. She presented to the Faculty of Dentistry at Dalhousie with a chief complaint of gum recession and some sensitivity. Relatively healthy lady, no allergies, and just on one oral medication for depression. Dental history, she had a history of orthodontic treatment as a teenager. Once again, she had generalized dental sensitivity, and she just presented at the Dalhousie Clinic for screening for comprehensive care. A restorative plan was developed at that time, and a referral was made to the periodontal clinic. She was a non-smoker and just occasional social alcohol consumption. Intraoral findings, missing 1, 6, 3, 6, and 4, 6, no active caries. Periodontally, very healthy. Generalized probing depth were less than or equal to 3 millimeters. She had generalized mucogingival recessions, facial and buccal surfaces, 1 to 4 millimeters. And she was someone with a thin biotype, and dedimus and erythavenous 2-2 and 2-3 was also noted at the initial examination. So our treatment plan was to do a connective tissue graft, 2-2 and 2-3. So pre-surgically, ibuprofen, 800 milligrams PO, rinsed with 0.12% chlorhexidine for 30 seconds. Local anesthetic, lidocaine, 2%, 1 in 100,000, 1 and 1/2 carps on the buccal, and palatal infiltration. And then lidocaine, 2%, 1 in 50, just a quarter of a carp, buccal infiltration around the 2-2 and 2-3. So I did a little envelope incision, 2-2 mesial to the 2-3 distal, but thickness flap was raised. Connective tissue was harvested from the palate in the second quadrant. It was sutured to the surgical site, to the recipient site with a 4-0 chromic gut. And then I coronally repositioned the flap with 5-0 PGA. Compression sutures were placed along with periocular dressing over the donor and the recipient site. So pre-surgically on the top left, you can see, I guess we'd call the Miller class 1 recession defects. In the middle is immediately post-op, and on the top right, once again, immediately post-op, where we took the connective tissue on her palate. She actually texted me 3 days later with this photograph and said, "Is this normal?" She was feeling fine, but she thought it was a lot of bruising. There's no bleeding from any surgical sites, but I told her this wasn't to be expected. I wasn't overly concerned, but I would see her at the 1 week post-op that we had scheduled. At the 1 week post-op she came, you can see bruising around her orbit. There's a surgical site. A little bit of sloughing of the overlying epithelium. You can see bruising upper lip all the way down her chin. You can see a lesion on her upper lip, and you can see bruising all the way down into her neck on that left side where we did the graft. And this was 1 week post-op. She was fine, but just more bruising than what we expected. So some questions for you. Is the post-operative sequelae noted in this patient extraorally and intraorally considered normal? If it's not considered normal, what would be your next approach? And what is the likely lesion noted on her upper labial mucosa at the 1 week post-op? How would you treat this lesion? And for further grafting procedures, how would you change the approach from the current protocol? And can you anticipate successful root coverage with the complications noted above? Thank you.